With this, I request now Dr. Sanjay Reddy to introduce our next speaker, Dr. H.P. Chandalia, sir.
The next speaker is the senior most diabetologist in the country. If you were any senior, I can't tell bigger than that. He's Director of Endocrinology, Diabetes and Metabolism from Jesloke Hospital, Mumbai. Director of Denmark, the Center for Endocrine and Nutrition Management at Mumbai. He's past president and patron of RSSDI, a faculty at the Alabama Medical Center, faculty at Grant Medical College in its earlier days, and he has more than 75 articles, originals and reviews in Scientific Journal, 20 authorships, is editor of International Journal of Diabetes in Developing Countries for more than 2 decades, editor Diabetes Today for the last 3 decades, and editor-in-chief of the RSSDI Textbook of Diabetes, 3rd edition, 2015. Welcome, Dr. Chandalia, sir, who's seen the pathophysiology of diabetes change over the pathophysiology, new things discovered. He's used to all the medicines in the world, but none other better than you to talk about inertia in diabetes practice. Over to you, sir.
Thank you. Thank you, Dr. Reddy. Chairpersons, thanks to Diabetes India, thanks to Dr. Banshi Saboo for involving in this talk. I'll be discussing if I can share my screen, start my slides. You can share the screen. Yeah, I'll try to share my screen. If there any difficulty, I'll ask you to help me. Enlarge it. Okay, all right. You see my screen and hear me, everyone? Chairpersons?
Yes, sir.
Yes, thank you. I'm audible because
you're audible.
The speaker, excellent speaker, the voice was not good. I was very happy to have joined earlier and listened to her. My topic is absolutely mundane, but a very important one in practice of diabetology. Something which is talked about often, but not implemented. So I'll take you very quickly in the span of 20 minutes through some of the important aspects of inertia we face in the practice of diabetology. I don't need to spend more time on the fact that glycemic control is very important and of course has a legacy effect proven in UKpedia, DCCT. So just quickly, we appreciate the DCCT and the follow-up again and showing that glycemic control is important. These two were important studies, mind you, because before these studies, there were questions whether control of glycemia really prevents complications. So I think these studies were that way extremely important at that point of time. And of course, we know about glycemic memory also. So I'll go rapidly. Now, the algorithms have changed considerably, but this is very classic. So I use that still, metformin and then those 6 options. And then you keep adding, further and go on escalating. And of course, now we are given, you see, some more additional criteria for selecting our therapy. For example, if the person has a weight problem, person has a lot of hypoglycemia, cardiovascular risk, our selection is different. So I'll not expand on that, but important that we are looking at it differently. We're using the guidelines. Now, the guidelines are very fine. They have been propagated by many organizations, including RSSDI, done a great job in putting out the guidelines a few years ago. And they're very good. But the implementation, when we go in practice, I want to show you the gap there. That is what we need to cover. So this is in the passing, this, I will not expand on this aspect, but this is not my topic today. But of course, you choose the correct therapy. But problem is that we really do not revise our therapy frequently enough to really control patients effectively. That is what inertia is. The inertia, this discussion came about I would say about a decade ago in the literature. showing that we have very good tools available to control diabetes, and yet we do not get good results. Why we don't get? So we started looking at this question, and this is how this question of inertia came. That is, we do not act in time, we do not act appropriately to really use these tools and achieve the targets that we need to achieve. So I think, and this is very classic slide shown in many CMEs, and you really wait for the A1C to go up. You call the patients usually at quarterly intervals, and you still find A1C raised, and then you add a drug and patient gets control. Or sometimes they don't get control with the change you made, and hyperglycemia continues. So this is what we mean by inertia. Delayed action or no action or inappropriate action in order to achieve the results that you are trying to achieve. So, of course, if you really act proactively and see the patients well within the time and go on escalating your treatment, you should be able to not only achieve control but manage it forever. You see here, A1C has stayed continuously down the threshold, what you desire, whatever you fix for that particular patient, and this does not happen very often. Most of the time, the A1C goes up, and then the patient sees you, and then you start changing your therapy. So this is the problem, you see. So chances of reaching A1C in time, means that you should really take a timely action, and this is what we've seen that. So now A1C goals also, of course, we keep discussing, and sometimes the patients fix their own goals. They read some newspaper, 8.5 A1C is all right, and they are further confused, of course, and they really think why the doctor is trying to bring my A1C further down. So it's very important for us to clearly understand the goals, and these are what we pointed out in one of our papers, the A1C goals, which are proposed, and the most importantly, I must tell you here, which is not brought out in the literature before we published this paper in the International Journal of Diabetes Development, the RSDI journal, that in pregnancy and diabetes also the goals are different for gestational diabetes, pre-gestational type 2 and type 1. This difference has not yet been very well pointed out by any author, so I feel this is very important that those who treat pregnancy in diabetes will understand why this difference in goals is important in pregnancy. What kind of glycemic goals are we achieving? And then we see what are the barriers to this, why we are not achieving, why we are not doing well. So this is some time back of year 2011 when we calculated, and we found that initial A1C, this was the distribution, and after controlling them for about 3 months or trying to control them for 3 months, you see we control almost half. In our clinic, we take 7.5 also as control because we really deal with people of very long-standing diabetes and with a lot of complications. So still 50% remaining uncontrolled. And this is what is even accepted everywhere, even now. Little later, now we are analyze the data, and we are doing a bit better. Now I think it has dropped from 50 to 40%. And world over, probably there is improvement. There is improvement in the percent of people who reach the glycemic goals, or the average A1C in the whole clinic, or the distribution that you see here. So there is some improvement, but 40% remaining uncontrolled. See, so what is this inertia? Is at what level? Where is this inertia? It is obviously, it can be with the patient, it can be with the healthcare provider, let us say diabetologists or diabetes educators. And of course, we use the word HCP so that, we can group the whole team into one. And of course, there may be system failure. The system is set up in such a way that it is not conducive to the achievement of the goals very easily. So we'll take up these three aspects during the remainder of the time. So the locus of control, let us look at what is happening at the end of the HCP, healthcare provider. And these are some of the problems you all face, lack of time. And sometimes, there is not enough education and training of people who are treating. Remember, the diabetes is being treated from family physician down to consultants, internists, and of course, diabetologists, endocrinologists. So I think at all levels, at some levels, the education and training is lacking. And this is what a lot of CMEs we have in order to improve that. Then the poor communication skills are there. You see, doctors are not trained in communication skills. Neither they understand behavior therapies a little more, which sometimes require as you go along. We'll see we are not as you go along. We all learn the behavior of the patients when we know how to tackle those problems areas that the patient discusses and how to change the behavior at all it is possible. Sometimes it is impossible in a given patient, but I think our communication skill have to improve in diabetology, because you really have to talk to the patient and make everything very clear. And sometimes, the lack of confidence in the minds of the healthcare provider, that this cannot be done, or you have a very difficult recalcitrant patient and you resign on the issue. I don't think it will work. It is impossible, and you really give up. So once there is no conviction on your part, obviously you can't reach the goals. This is very interesting, and I think a very simple table which I designed, and I've never seen anything like that earlier. You see, and when you start insulin less short or rapid acting, when do you change the dose? It can be every third day. Most of the time, every third day, you reach the steady state, whatever state you're going to reach, the concentration in the blood. Remember, any drug, about 3 half-lives, more or less, reach a steady state. So why do we wait for 1 month, 2 months, 3 months to call the patient and revise the treatment? So you see, in most of these drugs, you see about a week's time is almost the upper limit where you should revise the dose. So I think the adjustment of therapy lacking. We forget to tell the patient that I started you on insulin, but I need to adjust the dose, otherwise it will not work. You have to tell that very plainly. Patient thinks it will now work. It is the last resort treatment and I'm perfectly fine, so I don't have to again see the doctor for about 3 months. But this has to be made very clear, and you can see how frequently we should really revise. Now, how do you revise? What modality you use is a system problem. And many of us now do differently. Some of us do on telephone, some of us receive data on different apps, you see, and keep seeing those and response. Some of us have trained our educators to at least bring out, although they are not yet empowered in India to act directly or changing treatment, you see. Technically, by our laws, still it is to be done. And we all have certain methods. And frankly, what we use is really the emails, which is less obtrusive. And you really see a pattern of 3 or 4 days and then change the dose. If patient goes on transmitting each value to you and you go on seeing a changing dosage, it really is against the proper optimum way of doing it. It is against, because you're acting, is a knee-jerk reaction on single blood sugar is not really what you really need to have. So this, I think we have to know. We go by pattern recognition, we see the blood glucose pattern, and then we change. So I think frequency with which we change, this is a big inertia there. It has been shown that changing from one ineffective therapy to the other one, the delay can be as much as 1 to 3 years. 1 to 3 years. Many authors, there are a lot of papers on this, the delay, how much is the delay, but 1 year to 3 years is the common figure in the 8 or 10 articles that I saw. So you can imagine what is happening world over. This is not necessarily with us. So this is extremely important for us to do. Then, of course, we have to really, from at our end, we do not set up things properly. We don't tell the patient this is annual checkup is required, where you need to do certain more tests. Then you don't have to do any other unnecessary tests in between. You have to do self-monitoring. All that has to be told very clearly. You see, our laboratories have become so active in India, very unfortunately, in fact, very disturbing, that they approach people directly. I don't know whether it is ethical and whether the medical profession should take it up with the governments and really make some rule that you can't keep doing tests without a doctor recommending it. You see, so they do a whole battery of tests. Sometimes, most of the time, they never include the spot urine albumin creat ratio. So after you see the laboratories have visited my patient before me, only test that remains to be done, I've seen very frequently, is spot urine albumin creat ratio. Because these people don't take technical advice. They make the packages which are quite worthless, because there are 20 tests only 6 or 7 were really useful. So all that is happening in our country. And we still do not counter this because we are not very proactive. Medical profession is not very proactive. And in a way, it is wise because if we are proactive, how will we look at by patients? I'll discuss that later on as well, the patient's point of view also. But very important for us to do this. And of course, quarterly reviews where you do certain minimum things. So this should be very clearly stated to the patient. And the patient has to be told the goals, You ask them to do self-monitoring, but not many charts that are issued. And we introduced this almost 20 years ago, our blood glucose chart given to them. On the top states the goals that they should reach. So goals have to be set. They may be set differently for different people. And they have to be clearly told to the patient that these are your goals. Then the patient knows how close or how far he or she is from the goal. Remember that when we're talking about inertia, I've seen all the papers, not many authors have discussed the inertia in the other parameters, other like hypertension, hyperlipidemia are the other very common comorbidities. And there is not much written about that. But there are problems there. And sometimes you know very well that hypertension is a very potent cardiovascular risk factor and a very fast one at that compared to diabetes. And therefore, if you don't take care of that, ultimately you do not get good results. It's not yet discussed even in the literature much. But of course, it is simple common sense that all of you think of that. And of course, there, remember like home monitoring of blood glucose, a lot of my patients, almost all my patients, I insist they do home monitoring of blood pressure. So this is another facet. I don't think many of us are doing it proactively. And then they can detect, and we have to teach them salt restriction. Otherwise, you do not get good results with treatment of hypertension. And of course, little bit, we have to make them familiar with side effects of drug. Hyperlipidemia. The criteria are quite confusing in the literature. For example, the high, low intensity, moderate intensity, high intensity, then you don't even see what targets you reach now, according to some of the very, very important papers and recommendations. Although we all combine it by looking at also the values all the time, you understand, all clinicians have made their decisions based upon these two kind of guidelines, and they combine the both in order to give the patient best results. I don't want to go into details of that, but all of you will understand what I'm trying to tell you. You see, most importantly there, you see, the targets are not, the patients often read that the LDL cholesterol which are targeting, the lab says below 100 is normal. But they don't know that your therapeutic, you see, a goal is 70 or below 70. So you have to state that. Otherwise, they think doctor is unnecessarily pushing medications. And how badly Google, describes the statins. The most malign molecule on Google is statin. So you really have to educate patients. Then, of course, they discontinue as soon as, the lipids come down. Then sometimes they scale it down. They do all modifications. So I think we fail there. Now, if you see three targets, A, B, C, A is A1C, B is blood pressure, and C, LDL cholesterol, you see achievement of all three targets in many clinics world over is only 20% of people. How poor it is. Dismal, really. And of course, A1C targets are the worst in that. Blood pressure and lipid targets are achieved little more easily in the high percent of people than the A1C targets. So this is the state of art at the present time. And obviously, we need to improve that. And you know where the gaps are and where misunderstandings arise on this. I pointed out some of them. For example, antiplatelet therapy. People misunderstand very badly. Should you take one? Should you take two? Which one is better? How you should interrupt in small surgery, tooth extraction, how you should restart. Knowledge there is very vague sometimes in doctor's mind, and certainly in the mind of surgeons, dentists, all those other people who are involved. So it's a very, very, very difficult area. And the prescriptions have to be really very adequate. This is our typical prescription. This is for about last 15 years we use this model. And remember, you have to mention what the drug is meant for and what is the common side effects. This is very important, I think. In our country, the pharmacist doesn't give side effects to the patient. Other countries, the pharmacist gives a printout to the patient. You see that you watch for this, and this is how you use this drug. So it falls upon us to talk of some common side effects so the patient can alert you that I got this problem. So this is our typical prescription. See, so the prescription has to be as complete as possible. A1C, we monitor control with A1C. We know A1C has limitations. It doesn't reflect the fluctuations in blood glucose. So all that we understood. Now we are going to monitoring. We have not clearly tell the patient how often that person should test. We think everybody should test very often. Not really so. Some people need to test only 2-3 times a week. Some people need to test 2-3 a day. So there are extremes, and we really have to clearly tell all this to the patient. In your case, this is the frequency required, and the 6-point chart. And of course, we have now the sensors and all, and of course, any new innovation will be pushed hard. So now we are using sensor and the sensor, very beautiful graphs, patients see everything is done. But what is the actionable evidence? The actionable evidence, to my mind, there, I tell the people that I'll see the graph, but please take 9 observations every day. Swipe your reader 9 times a day and give me this 9-point chart. And last of all, I tell them to maintain the food and activity diary. Without that, really, you see those curves, and what will be your advice? What will your advice? Tell me, how will you advise the patient? The industry doesn't do all this for you. You see, they do not design any food and activity chart. You have to design. We have done that. One day is one page, They give sometimes 2 lines to fill up food and activity. There has to be timing. So, where is the problem? What food is the problem? Exercise is leading to hypoglycemic effect at what time? After 1 hour, 2 hours, 4 hours? It can be up to next day. Exercise effect in different people. So all that has to be really seen carefully and done. And of course, we have to learn to motivate people. Like, how do we motivate a young diabetic, type 1 or young type 2? You see, they are more worried about body image and appearance. It was really thought that when they use insulin pumps, type 1 patients will start eating a lot more, pumping more insulin, still remain under good control, and they will gain weight. It did not happen. There are studies on that. And it shows that body image was so important in the mind of the young people that they made sure they did not put on weight. And the pump data show that weight gain is not a common side effect. You see, and of course, you see, and they have peer pressure. They want a good energy level. They worry about their sexual reproductive function. So all you have to really understand what is the concern of the given patient. And you should know how to motivate a given patient. This strategy is different for different people. And we have not yet learned the behavioral sciences as much, which should be really also, honed by us. These skills should be honed by us. And this is what you see. And what are the barriers to patient adherence? When the patient is denial, anxiety, depression, sometimes complexity of treatment. Sometimes you make it very complex, we find difficult to understand. Cost is always a problem. Patients are paying from their pockets. Side effects are there, and we do not sometimes address them. A lot of misconceptions prevail. Can you teach illiterates? This was a paper by Diabetes Care by us long ago. You see, teaching illiterates, semi-illiterates in India, and we showed that it works since this was Diabetes Care, and this is the type of things were accepted at that time, you see, and of course there is good control achieved, control improved. There was no A1C even at that time when we published this paper. You see, now the locus in the patient. What are the patient factors which prevent this kind of achievement of our goals? And this is how the problem is with our patients, very poor health education as well as diabetes education in people. So they don't understand. The basic lack of trust in medical people, I must tell you that. This is very basic cultural problem in India. I've been amplifying this subject in many forums when I talk. This is very important for us to tackle that. And they don't know about complications. You see, treatment cost is a problem. Lifestyle problems are there. These all prevent us from achieving the goals, and they have psychological problems. You see, and of course, in our country, fake information, languages, sometimes you have to master. In Mumbai, for example, we have to master at least 3 languages if you want to communicate properly with the patient, 3 or 4 languages. And each region, you have to do that. We doctors sometimes don't have that much efficiency, lingual, mastery. So I think it's required. And then we have the alternate systems, which are very important in India to tackle. You see, the Indian culture and health issues, you see, it's a very poorly informed population with a lot of myths and misunderstanding, you see. They do not believe in regular follow-up, and continuity of care is not only in them, but we also, many of us have not yet understood what is continuity of care in diabetes. I have not seen many people talking about continuity of care or tackling this problem, showing how to do that. You see, the patients are highly suspicious of medical personnel. This is absolutely true. It may be true in many other countries as well, but in particular in our country, it is there. And of course, you see, and cost is always bothering them, of course. You see, the perception of how patients look at you, sometimes you won't realize. I have received love of my patients in abundance. You see, I have no problem. Yet I was able to perceive that the same person, if you see in heart of heart, really does not believe you, doesn't want to do what you want to say. So where is the gap? Why we are not able to inspire them, motivate them? Because of the cultural problem. They have a cultural hang-up, So they think of doctors sometimes as a god, sometimes as a good human being, and in the end as a devil. Whenever you give them a fat bill and they have to pay from their pocket, then obviously you are the devil. And of course, they're not trustworthy. They will touch your feet. But when your patient touch my feet, but I still don't know that they really trust me. This is a fact. This is cultural problem. You see, and they called my one colleague as he's very professional. So I was very happy when they say professional. You should be very professional in a good profession like this noble profession. But ultimately, when I talk a little more, I realized that professional by that mean fellow was charging adequately and charging more. So very peculiar words they use. Sometimes this is not a dictionary meaning, but you have to understand what they're trying to tell you. You see, for example, for obesity, obese child, they don't say my child is overweight. They say my child is extra healthy. Jada health hai, bahut acha hai uska. So this is how they do, you see. And then, of course, let us see. And this is how we looked at from millennia, how we looked at the medical people. At that time, there were no doctors, you see. And here is a Sanskrit shloka telling that, oh Vaidyaras, welcome to you. You are brother of Yama, god of death. You are the brother of god of death. You see, I bow down to you. Yama only steals away one's life, but Vaidya steals one's life as well as money. You see, this is how they look at. This is how they look at. And this is pervading in our culture, let me tell you. You will realize it when you see minutely what your patients are thinking. You see, patients expect all the odd things from you to be cured. One of our colleague who describes that I reverse diabetes, all of us reverse diabetes for many years, type 2, beginning 1 or 2 years, all of us reverse few hundred people. But one fellow now goes to Times of India, so reverse diabetes of 5 people. And then they start telling all of us, go to clinics and say, reverse my diabetes. After 15 years of duration of diabetes, wants reversal, you see. And they all want less medications. They bargain about medication. 3 tablets, can it be 2? Can it be 1? Every visit they bargain. They take less medicine is better. Taking medicine is invasion of your pious body. You see, it is invading your body. Taking prick, of course, is highly invasive. Of course, this is slowly changing. But you see, and they think they don't understand what insulin is, habit forming, and all those questions are there. You see, and they want reversal. Neuropathy, truly not reversal, except some symptomatic relief, and further progression can be stopped, and also kidney problems. So these are the attitude our patients have. And we have to learn to fight this. We have to learn to steer this by a little bit of behavioral approach, you see. And, I think I'll go rapidly. Say there are a lot of myths prevailing in our community, Alternate system medicine is a problem. And I'll give you some of my views because it really, sometimes we have not taken a clear stand on that. Modern medicine doctors have to take a clear stand. You know that I introduced in our textbook of diabetes, RSDI, a big chapter, 25, 30 pages on alternate system of medicine for the readers of modern medicine. MD and DM people are reading that book. And we introduced the chapter because I think it is very important for us to understand how to deal with this, you see. And of course, let us see here. These are kind of myths and all the face to that list is very big. So I don't want to describe all of this. All of you face this all the time. It's just for you to bring to your kind attention that all this is happening in patient's mind, you see. So I think a lot of misconceptions prevail, and we really have to keep educating them extensively to do that. Alternate systems of medicine, how do you grapple with that is very important. I have not treated any type 2 diabetic who had not taken indigenous treatment simultaneously with my treatment or before seeing me and after seeing me both. See, I have not treated one. Whatever you say, they will take indigenous treatment. You see, and they have wrong concept of the benefits and side effects. I know side effects of some Ayurvedic medicine than Ayurveda Acharya know. I know which one damages kidney, which one causes hemolysis. I have had a pilot, trying to cure his diabetes so that he can fly again. You see, and got a bad hemolysis with the Ayurvedic drug. We have studied all this, mind you. We modern scientists can study all this very, very well, and doesn't take us time to understand this. You see, so I think now don't wish it away completely, this alternative treatment. For example, editing International Journal of Diabetes in Developing Country, I had to do for about 22 years. So from the formative, very small state of a Patrika to an international journal of repute. And now, of course, our colleagues are doing a great job on it. And there, I counted in 2 years, 6 studies on different herbal drugs we had published in our journal. They are very well done scientifically, absolutely flawless, and shown results also. So there are some results. You see, there are 200-300 trees, barks, leaves, and roots which can have effect on blood glucose. Many other parameters as well. So don't have complete denial of some of these scientific facts, because when you counter that with the patient at Ayurveda, Yambag or something, they lose trust in you completely, that you are anti-Ayurvedic, so you really, and sometimes they may take you anti-Ayurvedic as anti-national as well, huh? Although there is no relationship to Ayurveda appreciation and nationalism, but they will take you as anti-national as well, huh? So be very careful, So these are well done studies. So what do you do really? See, we have some peculiar ideas like this. Now, if you allow a patient to take your treatment and take the herbal treatment side by side, which also you carefully see that there is no pearl basam in it, no other basma in it. Pearl basma killed one of my patients, you see, pearl basma. And the amount paid was more than the price of the pearls even, I wish he had bought a necklace for his wife, pearl necklace, instead of taking pearl basma, you see. So you see, so it's very important to see, if you are allow them simultaneously, all the good effects that will accrue, even glycemic control, they will attribute to herbal drug and not to your drug. If there are any side effects, it will be at your door. Your medicine will produce this side effect. So be prepared for that. How to counter it, how to explain candidly and based on the basis of science that this is not a side effect of this drug. So this is very important. You see, now if you like, you allow. You may not allow, you may counter it by easily saying that the drugs can work in very early stage of diabetes, and we should accept that they can use in prevention of diabetes. My fond hope is that we will establish these drugs also with scientific study. And RSDI is concluding now a study on the methi powder, which has gone on for 7 years, and they are about to publish it. And probably prevention, impaired glucose tolerance group, it may be the right thing to give. You see, so let us position scientifically some of them in the right place, so that we don't keep encroaching in the areas where they are not supposed to be. So we hope, I think Banshi is listening. So Banshi is one of our biggest activists we can have. So I think Banshi, you take up this. I think this is very, very important. You see, so how do you advise them? Do you advise them to stop one of them, or do you ask to continue both? Please decide your strategy clearly, but do not antagonize the patient straight, because they lose trust in you, because trust in Ayurveda and this healing is so strong that you cannot condemn it. And maybe keeping your mind open, there are areas where it can work. I purposely shown you scientific study that we publish after being referred by 3 referees, mind you. These studies in IGDDC don't go through very easily, mind you. See, so I think this is where we are now. This is my last slide. The system problem, and we have not developed systems. We don't have a good record system. We don't have a good reminder system. RSDI is doing a great job. I know that Sanjay Agarwal told me that we are developing where we all can use a uniform record system, and the same can incorporate reminders. Reminders are very important. You think patient will mind it? No. We started sending reminders. We thought they will think that doctor is trying to woo us, he wants to enhance his practice. But frankly, they were very grateful that we reminded them. These are I was wanting to come, but he could not overcome his inertia. So this reminder served him to overcome the inertia and came. So frankly, most of them have taken it very kindly and reported quickly when we reminded them. Record system is very important. I don't want to enlarge on that. You see, the intensification logistics are very poor. There, the inertia is, I told you, you might give time after 2 months after giving certain dose of insulin or giving one DPP-4 inhibitor and see me after 2 months. You don't have to see patient after 2 months. Intensification strategy have to be clearly defined. And you have to find a way where it doesn't encroach upon your time so much, and yet you do it. So you all are ingenious in doing that. So please do that. And of course, some poor diagnostic facilities. To my mind, diabetology should be practiced together with laboratory, routine laboratory being there, and little bit cardiac evaluation should be there, and testing of peripheral nerves and feet and all is very important. I think all that should be done under one roof because it makes it easy for the patient. So I think these are the ways where we have to cast off our inertia, friends, and I think we improve the lot of our patients. And by doing so, we'll improve our lot as well. And we will have a better status in the society if we understand some of the behavior problems and really help people. See, so thank you very much for your patient hearing. And if Chairman allows, I'll take few questions right away or whatever we desire.
Yes, Sanjay.
Yeah, so thank you very much. That was an interesting share of all the experiences you have gone through so many years. Patients, doctors, society, and what needs to be done. Thank you very much. I think it was a wonderful talk for everybody who's listening to see where you should improve yourself, probably communicate better, spend more time with the patient, and also incorporate. I've took some snapshot of certain things to say that it has always been a practice improvement model. I think it's a constant evolution in all the three times. Thank you very much, sir. There are no questions as of such in the chat box. So, Dr. Banshi, you want to add something?
Yes, so thank you, sir. First of all, thanks for this very important topic which you have discussed and shared with all the delegates. The clinical inertia topic which you had talked with before some time, we had also done in our country from RSSDI, a national level, that what is the average A1C at that point of time people escalate the therapy, and the scenes are same that up to 8.5 is still and doctors blame most of the time the patients, and patients blame the doctor that the therapy is not escalated at right point of time. And we all believe that most of the time it is the patient also does not want to take insulin at right point of time. So do you believe that after this newer therapy which had come, and mainly those does not cause the hypoglycemia, will improve the care for patients and the clinical inertia will be lessened? Because in last 15-20 years, if you see the data, the average A1C of our patient, even in spite of so many medications have come, is still the A1C is remaining around 8.5 or more. So what is your opinion on that?
No, I think the newer therapies we don't produce hypoglycemia will definitely improve patients' lot. In fact, already I showed two sets of data. Once our 2011 ending, 2018 ending, and we are already salvaging about 10% more. So patients bringing them to the target. Drugs are very potent. Insulin can control anyone for that matter and crash the sugar from 300 to 30. But unfortunately, that frightens the patient, and the patient, cooperation you will lose completely if you produce bad hypoglycemia. So I think non-hypoglycemic therapies which are presently available, and most of us use those in preference to sulfonylureas, glycides, or insulin, frankly. Whether less insulin use will occur in type 2 diabetes, I think slowly, the data will emerge. But to my mind, yes, it will to some extent. That doesn't mean that insulin will ever be extinct. You see, it will stay on. So I think these are very important. I think we'll be able to do better. But some of these are imponderable questions like changing patient behavior, all these which sometimes we may not be able to overcome. And there are basic limitations of therapy, like insulin exhibited in the good dosage will always produce some hypoglycemia. So So this sort of things will always, I think we'll have to have something totally different. How we are able to get better control in hypertension and in lipids, because the therapies available are effective and the side effects are minimal. The same thing we have to achieve here. So even if we go on singing praises, we got wonderful products every day, new, and obviously whatever new has to be hailed and appreciated. But to my mind, we still should look for better therapies of diabetes. And I think the non-hypoglycemic does work one step in that direction. We still need to look insulins which will have more predictable response, which will have a coefficient of variation, which will have still a lot of variation. All those problems are there. So I think we need to progress. We have to have better tools also. Although we think we are in a wonderful, we have reached the height of our development. To my mind, we are still not there.
Thank you, sir. Thank you very much for your words of wisdom.